Hello, can you hear me?
There we go.
You took away the option to call in for volume, so now I can't hear you.
So say that again.
Oh wait, hold on. Let me try something.
Are you able to hear me?
Hello, can you hear me?
I can hear you. Can you hear me?
Okay, great, thank you. That took a few tries.
I'm going to, let's see. Let's have you start. Well, actually, for right now, you can keep your video off unless you want. There you are. And that you can have it on or off right now. And as people come in, when we get started, we'll do a quick introduction, roll Dr. Black's video, and then when we get to the end, you'll want to, at the end of that, back to the Q&A, I will put on the screen the questions as they've been rolling in. And the participants are upvoting those, so the ones at the top are the ones that most people have said that they're interested in knowing about. And then you guys can be on camera or not for that. That's up to you.
Sounds good. I think while it's rolling, we should keep it off camera, and then for the Q&A, we'll go on.
Yep, I think that's a good plan. So
Awesome.
I started us good and early tonight because I was afraid. This is my first one doing it so live, so I thought I would hop on early just to make sure we were good to go. And so I'll just keep an eye out for Dr. Black, and yeah, hopefully we'll be able to start right at 7:30 or
Sounds great.
7:30
Thank you.
Eastern. Okay.
Thanks.
Good evening, everybody. You have two screens on, you have to turn one of them off, otherwise we have a really awesome echo. Welcome to our presentation tonight with Dr. James Black and Dr. Sherene Shalhub. We are getting started here in just 1 minute. I'm going to invite our presenters to unmute and bring their cameras up for a second while we get started here. My name is Angela Christ. I'm the director of the Loeys-Dietz Syndrome Foundation and the director of marketing at the Marfan Foundation. So kind of wearing dual hats these days. There's Dr. Black. Just wanted to introduce both of you all, if you want to say hello while we get started here tonight.
Good evening, everyone. My name is Jim Black. I'm a vascular surgeon at Johns Hopkins Hospital.
Hi, and good evening, everybody. I'm a vascular surgeon at the University of Washington.
Oops. Oh, no. It's gone. Hang on. Press the wrong button. Share. I think I've done this before. Okay, we're back. Let's see. My apologies. On the wrong screen. I'm going to try this again. This one. And we're almost there. It's choosing the wrong screen. And I kept saying I had it going, and then I pressed the escape button, and now I'm fighting with it again. So hang on just a second. So got me on there. Well, close this one. Sorry, guys. Let me get this going. Just 1 second, everybody. We're just having, I'm having a little technical difficulty here, and I'll have it fixed here in just a second. Slideshow. And share. Over. For some reason it's choosing the wrong one. Had it all up. Okay, there we go. Okay, so tonight's topic is vascular surgery in the LDS community, Loeys-Dietz Syndrome community. So we're going to be I'll roll the presentation here in just a second. But before we do that, just wanted to mention that to our audience, we are so thrilled to have you participate in the International E3 Summit. We've got well over 2,000 participants who are here for the educating, empowering, and enrichment of our community. This is all brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation, the VEDS Movement, and our partners in Europe at Vascular. We're also grateful to our presenting sponsors, Brigham and Women's Hospital and American Communication Construction. So before we start, just wanted to note, if you have questions, you can put them in the Q&A in your screen that you're viewing on through Whova, whether that be online or in the app. And we also want to mention that you all know the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. And opinions stated in each of these talks are those of the speakers and not necessarily of the Marfan Foundation or Vascular. Tonight we are so fortunate to have both Drs. Black and Dr. Shalhub with us. And so without further ado, we will get started with our presentation. And I will we'll all turn off our mics and our videos to give a full screen to the presentation. Having an audio problem here, guys. Just give me 1 second.
Angela, can you hear me? Hey, Angela, can you hear me? I can share the video from my screen if you'd like. Okay, I'm just going to go ahead and share my screen.
We're going to talk about Loeys-Dietz Syndrome today, as I mentioned. We know these are related to mutations involved in the TGF-beta receptor, and then actually several additional types of Loeys-Dietz Syndrome have since been discovered after the original description of the TGF-beta related aortic disease back in 2005. The arterial tortuosity, the hypertelorism, that is the slightly white space of the eyes, and some very, very subtle craniofacial abnormalities create the characteristic triad. And although initially what we saw from Loeys-Dietz syndrome was the most severe end of the spectrum, with types 1 and 2 having a concern for aortic rupture and early death, what we now appreciate is Loeys-Dietz is really a spectrum of diseases. And in fact, even among type 1s and 2s, as well as the 3, 4s, and 5s, we now see patients living a very long time with Loeys-Dietz syndrome and many, many different manifestations. But we also know from Loeys-Dietz this is really a pan-vascular condition. We see, for example, the carotids looking very tortuous. Here's a patient with carotids that do a few loop-to-loops. It's a very common manifestation of Loeys-Dietz syndrome. We also know that you can see aortic root aneurysms in many patients. You can also have aneurysms of the descending thoracic aorta. You also have aneurysms of the abdominal aorta. And there are other ones too that are seen in the other branch vessels farther out. The key points about Loeys-Dietz that I try and reinforce with patients, as well as with other practitioners who may be managing you at home, who might not be quite as involved in the regular care of patients with connective tissue disorders, is to understand that this is really a pan-aortic aneurysm syndrome. We do see aneurysms in other locations, but we really should be able to, on younger patients who present with dissections and other vascular issues, we should be able to come to this diagnosis on physical examination. Again, looking at those spatial features that lead to the diagnosis. And identifying one as Loeys-Dietz syndrome really is important to expedite the surgery that one would need. Because of course, for vascular EDS, there's some hesitation about surgery and the balance of the tissue fragility and the surgery that needs to be performed as a balance that has to be struck between the patient and their surgeons. In Loeys-Dietz syndrome, the tissue integrity is such that surgery is a very good option for many patients. We don't have the same worries. What we discovered from our initial operative experience in Loeys-Dietz syndrome is that the operations can be carried out quite safely, but we saw that patients would develop recurrent aneurysms, both contiguous to the repair as well as downstream or even upstream from the prior operation. So we've sort of advocated that if we're in the chest to fix an aneurysm, that we should fix all of the vessel in the chest, mostly to avoid these reoperative exposures. And so this notion that Loeys-Dietz syndrome can affect the entire aorta is something we try to strike the balance on. So for example, the old operations we used to do to handle extensive aneurysms related to Loeys-Dietz syndrome might have included a little patch of aortic tissue left behind. These little patches were susceptible to aneurysmal degeneration. In fact, it didn't happen very quickly, but it was usually within 5 or 10 years. And of course, going through this operation twice to tackle these areas of aorta is not anything that we would want to do on any routine basis. So we've tried to switch off of that to a different type of technique. This is called a branch graft, and these branch grafts will then essentially be sewn directly to the origins of these vessels. That way there's no aortic tissue left behind. Here, for example, this could be sewn to the graft in the arch, or the descending, this could be more distal. So that allows us to sort of repair the entire aorta through the full advantage of any surgical incision we would make into the area. One of the concerns that we come up with as practitioners in dealing with Loeys-Dietz syndrome and Marfan's and others, of course, is the notion of about a type B dissection. So we know for patients with connective tissue disorder and Loeys-Dietz syndrome in particular, that aortic dissection is one of these catastrophes that we have to tackle here and there. And initially, we thought that there was something going on with the descending aorta, and that there probably is a biological reason for this. And this was a study dating back now close to 20 years, but essentially showed that the same vascular smooth muscle cells that are involved and some of the changes we see in Marfan syndrome actually traffic and high density throughout the entire aortic arch. And so this zone of aorta, just beyond the artery, muscle-claving artery here, feeding out to the left chest, this zone of aorta is probably at risk for developing a type B dissection. That is a dissection that extends from the vessel down through the chest into the abdomen. Here's an example of one of those on a CAT scan of a Loeys-Dietz patient. The time to onset for type B dissection when someone has had their root aneurysm repaired in Marfan syndrome is 14 years, but interestingly, this is a little bit different for Loeys-Dietz. Sometimes we see the type B dissection happen before we get into needing an aortic root replacement, and that's a unique distinction that's important about Loeys-Dietz syndrome. It's not always the aortic root that requires immediate surgical replacement, or for that matter, is even the first segment of the aorta to be replaced at all. So again, a pan-aortic syndrome, so therefore we have to keep an eye on the whole aorta itself. Importantly, when people have a type A dissection as the index event in their connective tissue disorder, very soon, only 2.5 years later, we're having to tackle the aorta downstream. Over the course of a lifetime for patients with Marfans, we saw that many of them required replacement of the descending thoracic aorta. So this is an important distinction, which is why we like to avoid dissection in patients with connective tissue disorders, because we know if the dissection occurs, that usually then rolls into other operations that will happen down the road. But if we can handle the aneurysms electively, there's many, many years in between operations over time. And we know that beta blockade is protective against type B dissection in several studies. And so I think there's good evidence to consider beta blockade in addition to other medications for Loeys-Dietz syndrome. One of the concerns about type B dissection and how many vascular surgeons will treat it is to use a stent graft. And a stent graft is an appealing option for many reasons, in the sense it's usually performed through a small incision or even no incision in the groin. The devices then sit inside the aorta. But importantly, connective tissue disorders were an exclusion for all the devices to date. So in fact, if someone had a connective tissue disorder when they were identified in these clinical trials related to these devices, they were all excluded. And the concern was the device has radial force. The device tends to straighten because they're metallic. And they also have some bare metal stents. And so here, for example, is a patient who has a bare metal stent on the front of this endovascular stent graft, and it actually is perforated through the aortic arch. It's been that way for years. The patient actually has no symptoms of it, but of course, you know, there's something that just seems intuitively not right about that situation. We worry about the fragility of the aortic wall, also with where it interfaces against the stent, and whether or not that interface of the normal aortic tissue against the bare metal stents could lead to a new dissection occurring at that interface. And in fact, when a large series that came out of China demonstrated that a new dissection related to placement of a stent graft was actually the most common complication of Marfan patients. And in fact, this dissection seen here in the CT scan, you can see here the stent graft here, the metallic marks of the stent graft, and then you can see this dissection is lifted up right at the edge. And that's usually related to the stent graft itself. In this particular population, Marfan patients accounted for 12% of all these acute emergencies. However, they were only 1% of the entire study population. So obviously there's a skew towards connective tissue disorder patients having trouble with stent grafts. We also know that not just where the stent graft interfaces with the aorta at the top of someone's descending thoracic aorta, they can also have problems down here. So the stent graft can actually induce a new tear inside the prior aortic dissection. And there was a very high incidence of that when they looked back in this series out of Arizona at patients with Marfans versus those who did not have Marfans. And in fact, you know, this was a difficult problem. This led to, you know, significant mortality and required some surgical conversions. There really isn't anything particular about any of the stents on the market, whether you have one device versus another. They all seem to have this problem. And so it's something we tread very lightly on when we're considering aortic intervention in a young patient, and particularly even a young patient with a connective tissue disorder. And in a pinch, though, an endovascular repair makes a lot of sense when your aorta is ruptured, and it's the availability of an expert surgeon to fix a problem that's not right there. Sometimes a TEVAR can get you out of the woods. And so the thoracic stent is placed, but then we saw in this one study there were complications around that. Many of them required another intervention related to the stent, and a great many in this series still developed other aneurysms despite the stent. This is another series, again, small in number, but many patients continue to require reintervention, and the aorta beyond the stent itself continued to dilate towards an aneurysm. The largest series to date showed, again, many of these patients who have a stent placed in connective tissue disorder required a surgical conversion. Patients had a second surgery. Most of those also progressed to require an open surgery. So in the field of thoracic endovascular repair, to address an aneurysm in a patient with connective tissue disorder, what is really the state of the art? Well, I think the evidence suggests that TEVAR is safe in the short term, but there are device issues that are really central to creating a new aortic complication, especially in the setting of a type B dissection. However, there's clearly a benefit for thoracic endovascular repairs to stabilize an emergency in a situation when you need a bridge to have definitive therapy at a center that has more experience, and you're in a smaller hospital where you have a rupture. When you have a graft sealing zone, that is to say, you have a graft above the area of the aneurysm you're worried about or having to treat, and you have a surgical graft below the area of the aneurysm you're thinking of treating. That's what we call a graft-to-graft sealing zone. So the stent graft is just bridging between two pieces of surgical graft material. It's a very stable sort of situation. And of course, lastly, when in a pinch again, to just get a patient onto the next level of care where they can have consideration of open surgery with a reasonable expectation of success. I've been asked the question several times by patients who had thoracic devices placed in the setting of a perhaps not yet diagnosed with Loeys-Dietz or Marfan's or other disorders. And, does a stent graft obviate a future surgical intervention? And in fact, it doesn't. We have ways that we can still keep a stent graft in place if the stent graft has been behaving well over time, and then we can use our standard surgical grafts to connect directly to the stent graft itself and then finish out the repair to the critical abdominal branches feeding the liver, intestines, and the kidneys. So ultimately, our Loeys-Dietz management at this point now, really in a contemporary fashion, is about the multidisciplinary evaluation between a geneticist, an anesthesiologist, and a surgeon. Having a group is experienced, someone in each of those groups is experienced is really important for managing the unique needs of this population. There are operative techniques that we can use to reduce operative trauma around the time of aortic repairs for patients with Loeys-Dietz and other connective tissue disorders. And currently, stent graft therapy for patients with Loeys-Dietz and other connective tissue disorders is defined in a very limited fashion. That is, these bridge to referrals, revision procedures, and these graft-to-graft sealing zones where we know we have a stable fixation point for these relatively stiff and metallic stents in a fairly young aorta. So I want to thank you all for inviting me to speak today. We're going to be doing some live Q&A. Look forward to your questions. Thank you.
I think you're muted, Angela.
If you have any questions that you would like to go ahead and place into the Q&A that you haven't already, feel free to do that. And in the meantime, we will invite Dr. Black and Dr. Shalhub to go ahead and come back up onto the screen. I am going to share the questions that we have seen so far. And if you'd like to go through those, you can, or, we'll probably see some others come up throughout this. But these are the ones that have been submitted that several of our users have already shared that they were interested in hearing more about. So if you want to start with maybe the top couple here, and then we'll see what else comes in. And like I said, if you're a participant and have another question you'd like to see answered, feel free to drop it in the Q&A.
Angela, can you turn my video on? It says I'm still locked out.
Okay. Should be able to do that, but stop this and bring you back. There you go.
Thanks.
Okay, back over here. Okay, then we need to spotlight you. Okay, do you guys want to go ahead and I'll get you spotlighted here so that you're on the screen.
Hi, Angela. I can get started. Do you want to just read the first question? It's not zooming in very well.
Okay, Yeah, sure. It says, is it better to have vascular surgery early or as late as possible in life, considering here ease of patient recovery, impact of treatment, costs, and side effects of operative and post-operative meds?
That's a great question, and actually it's very common that people ask that. The way we decide if surgery is indicated is usually related to the underlying pathology, like what is it that we're seeing that we're trying to repair. So when we think of Loeys-Dietz, we think of somebody who has aneurysms and dissections, can be all over the aorta potentially, as well as the arteries. And so based on where the aneurysms and dissections are located, that dictates when is the right time to operate. So for example, we have size criteria for aneurysms. That, let's say the aortic root aneurysm, where we measure the size of that. And once the size is reached, that's when we recommend surgery. But we don't preemptively just replace the arteries when they apparently look healthy or they don't have dissections or don't have aneurysms. Dissections, for example, again, depending on where the dissection is located, if it's causing problems such as cutting off the blood supply to the organs, or if it has an aneurysm that is growing, then we do want to repair it. But if it's stable and it is not growing and it is not cutting off the blood supply and there's adequate blood flow in those cases, then we watch them and we manage them what we call medically with medication. Jim, do you have additional comments on that? Because that's a great question in terms of timing.
Sure, I think there was, particularly initially in the experience of the Loeys-Dietz patients, dating back into 2007, we were much more aggressive about surgery, even to the point of any aneurysm for fear of rupture. We now have a much better understanding that Loeys-Dietz is a spectrum of a disorder, and there are many patients who will grow their aneurysms very, very slowly. So even someone with an aneurysm, if it's not at the threshold for diameter threshold for surgical repair, as Sherene mentioned, then we would wait and watch. And I think that balance is one that patients strike with their surgeons and their genetics team very often.
Okay, great. On to the next question then. Does that sound good? All right, so here we are. It says, is there a list of facilities that perform LDS-related procedures, i.e. descending aorta replacement, or on a relatively frequent basis? It would be nice to have when traveling just in case. Sure,
so I think generally speaking, and actually we did a research paper on this showing that in an emergency, an acute dissection should be managed as quickly as possible, and oftentimes those can actually be managed in a community hospital in emergency. A descending thoracic replacement's a little bit of a different game in terms of the way the surgery has to be performed, the various protections that have to be put into place to guard against really significant complications. So simply put, some of the university centers, particularly working through the Loeys-Dietz Foundation to identify practitioners who could be in your area when you're traveling is certainly something that's reasonable. The Loeys-Dietz Foundation has a very worldwide connection, and so those things can be leveraged if one is concerned while they're traveling.
One thing I will add to that as well is that, the Marfan Foundation does maintain a list of Marfan clinics, not all of which have Loeys-Dietz clinics associated with them, but it would be a good place to start, and you can find that by going to the Marfan website, marfan.org, and maybe Deborah, if you could drop in that link to the clinic directory, that might be helpful for folks. Any other thoughts on this?
I agree. That's another very good link. The Marfan Foundation link, the Loeys-Dietz Foundation links are going to have good resources in that regard.
Okay, next question. Is it possible to survive dissections? Is there a time you should have surgery to prevent dissections in these arteries for LDS patients who have already had dilations or aneurysms?
So that's also a great question. Normally, yes, most people do survive a vertebral or artery, carotid artery dissection specifically. The main concern that we have is the risk of stroke at the time of dissection when it does happen. Thankfully, most people who have these dissections don't have an associated stroke, but will present with neck pain, and that's how we diagnose them with these carotid artery or vertebral artery dissections. And in general, the way we manage them is what we call medical management with blood pressure control. Sorry, I have some background noise. Blood pressure control as well as antiplatelet therapy, usually aspirin. On rare circumstances, we add anticoagulation, meaning thinning the blood, beyond just an aspirin. In general, again, we don't operate on these arteries ahead of time as a prophylactic repair, unless, what Dr. Black had mentioned earlier, like if somebody's having an arch repair, for example, then we do prefer that we repair these arteries if the chest, in the component that is in the chest, as opposed to up in the neck itself.
Okay. Dr. Black, do you have anything to add to that, or should we move on to the next question?
I think it's important to remember that vertebral dissections, although we see them quite commonly in Loeys-Dietz syndrome, are relatively rarely progressing to surgery. And some of that's because the vertebral arteries are paired. They run up the back of the neck and then they meet to become one vessel. So particularly as one vessel is becoming dissected or it's starting to have a lower blood flow on the basis of that, it's pretty well backed up by the other vertebral vessel. So indeed, many times, if it comes down to an aneurysm in the location of the vertebral vessel, we're usually just going to clot that off with catheter-based therapies or a simple surgery. Complex reconstructions are exquisitely rare for vertebral artery dissections. Carotid dissections are a little bit of a different game, but in Loeys-Dietz syndrome, most of those carotid dissections are in relation to an aortic dissection. So again, what Sherene mentioned, repair them if they're in the same zip code as the repair that's currently ongoing.
Okay. Let's see, what do we have next? What is the recommendation for surgical intervention for a brain aneurysm in a person with LDS? Are there any guidelines as to the size of the aneurysm when intervention should be considered?
So, brain aneurysms and Loeys-Dietz syndrome do occur. The brain aneurysms, in difference to aortic aneurysms or subclavian aneurysms, are a totally different decision algorithm. And indeed, many brain aneurysms have very malignant appearing morphology. That is, the aneurysm itself appears extremely irregular, and some of those things will tip over the decision for an intervention, even though the overall diameter of the aneurysm may be actually somewhat small. So that's a very much a person-to-person answer. And again, experts through the Loeys-Dietz and the Marfan Foundation can help guide those things. We have connections to neurosurgical specialists and neurovascular neurologists that could help guide some of those specific recommendations.
Dr. Shalhub, is there anything you'd like to add to that, or are we ready to, or would you like me to move on to the next question?
I think that was a great answer. I mean, and we just consult usually our neurosurgical colleagues, and like Dr. Black mentioned, we also look at it on a case-by-case basis. So yeah, let's jump to the next question.
Okay. Are there any specific risks that people with LDS or Marfan who have a history of pneumothorax need to consider in planning for valve repair or vascular surgeries?
I'd say the big consideration is making sure that the surgeons know that there's that history, and certainly we ask specifically about that. But certainly if nobody asked you, you do want to volunteer that as part of your medical history. And then part of that, again, it's variable from person to person. Some people have had it managed, what we call conservative management, and then pneumothorax is resolved. And some people, needed other interventions like a VATS procedure where the thoracic surgeon will go in and rough up the surface of the pleura to make the lungs stick up. Either way, certainly it's something to discuss ahead of time before surgery. And depending on what the operation that is happening, we will have a discussion also with the anesthesiologist with regards to planning of how, the pressures that they're going to use during intubation and when people are on a ventilator. And then we're just aware that this is a risk factor. At least that's how we, certainly approach that at the University of Washington. Jim, any additional thoughts?
No, I agree. Yeah, those pneumothorax is common across a wide variety of medical conditions, and for the most part, they're easily managed. If someone has what's called a pleurodesis, that is a procedure that causes the lung to scar to the chest, that can be a significant problem for surgery on the descending thoracic aorta. But short of that, it really shouldn't affect surgical planning dramatically.
Great, thank you both for that answer, or for your answers. Next question is how best to work with our cardiologist and surgeon in broaching the subject of our desire to keep an active / slightly extreme lifestyle. Want to rock climb, scuba dive, skydive, etc., but want to do as safely as possible.
Yeah, I mean, this is a very common conversation we have in clinic. Obviously, patients in the Marfan Foundation, patients in Loeys-Dietz Vascular EDS, very young. So they want to keep up with their buddies. They want to do the things their buddies do. And, simply put, it's a balance. And there are recommendations to avoid burst type of activities. So for example, I encourage, steady state exercise, moderate level heart rates. You can certainly break a sweat and even huff and puff a little bit, but exercise to exhaustion, where you're sort of panting and leaning over is probably a little bit beyond what we would encourage as experienced cardiologists and surgeons who've seen the sort of the underside of when things are pushed too hard. It's important to remember over a very, very wide range of heart rate that blood pressure is very stable, but when your heart rate gets to around 70–80% of max, blood pressure goes up really precipitously. So rock climbing, can certainly be considered steady state exercise unless you have a little problem with gravity. Same thing with skydive. But if you're doing these activities, you're managing heart rate, managing breathing, I think those things are okay. The concern you always have about skydiving and scuba diving is, of course, when you're down deep or up high, there's no place to stop and take a breather if you get into trouble. And that's the nature of those activities. So it's, again, a balance that patients have to understand. And we do encourage exercise. I think what's best for the body is best for the aorta, what's best for the mind. So it all goes together.
And I would add how best to work. I mean, how best to work is to have that conversation with your team. You may not like the answer per se, but you still should have the conversation. And it does fall down to being an individual choice at the end of the day. Some people are risk averse and some people are more willing to take more risks. At the end of the day, you have to do what makes you feel, I would say, happy. I mean, for the lack of a better word. I mean, you have to balance that.
For sure, and I'm just dropping in our physical activities guidelines from the Marfan Foundation as well. We always echo what both of our doctors tonight have said, that you really need to have that conversation with your individual physician or your team, but there are some generally accepted guidelines that we just like to share overall for folks who are asking these questions. On to the next question here then. Is there guidance or research into when to operate on babies or toddlers? A rate of change or size? Our 5-month-old with LDS has had severe dilation of the aorta root and ascending aorta from birth. Haley here gives some measurements, measured 21 millimeters and the ascending 18. Both had increased since the initial assessment, but has been stable for the past few months. So certainly this is a very specific example, but do you have thoughts on the overall question here, or perhaps even specifically on this child's measurements?
I wouldn't comment particularly on the measurements. The goal in early surgery in Loeys-Dietz or Marfan is to really get the patient into an aortic root or an aortic valve prosthesis that would be suitable to carry them through into their adult lifetime or timeline, I should say. So that's going to be a decision that, based upon the conversation with the local cardiologist and local cardiac surgeon as to when that sort of area is crossed. With an ascending aorta of 18 millimeters, if valve replacement was required, that might be a little bit small a valve to carry someone into adulthood. But again, a lot depends on how fast the aorta is growing. If it's stable, which it sounds like it's done so, then that's great. Then maybe it's a wait and watch proposal right now.
Anything to add to that?
No, and I think that's how, we like to follow things over time to see if they're changing as well, because that does dictate how soon we want to operate if there's a lot of change. But if things stabilize, then that's helpful information to know.
Great, thank you for that. Next question here. In your experience, do patients with LDS go on to need surgery sooner or more often for type B dissections than Marfan patients?
So I would say that depends on what kind of Loeys-Dietz syndrome we are looking at. There's definitely variation within the different types. So for example, TGF-beta receptor 1 and 2 variations will have more rapid growth than, for example, somebody who has SMAD3 mutations. And so again, it depends on the underlying mutation. And even within certain genes, there's also variation. So again, it's individualized rather than generalized.
Dr. Black, do you have any additional thoughts?
Yeah, it's dissections are very interesting. Particularly for type B dissections. I've appreciated that in difference to patients who don't have an underlying connective tissue disorder, we tend to see a condition called malperfusion more often. That is, patients with connective tissue disorder, when they have a dissection, might have trouble with kidney or spinal cord or leg blood flow. And some of those things tip over the need for intervention earlier than in others. So I would say in general, patients I would not sort of have the loaf between Loeys-Dietz and Marfan's. I would say that in general, yes, we see people needing surgery sooner in connective tissue disorders across the board than if someone did not have connective tissue disorders after type B dissection.
Thank you. Just a reminder that if you have a question you would like to have answered tonight, please drop that into the Q&A you are viewing. There is also a chat function in your screen there, and there are some resources being linked in that space. So we're using those, one for questions, one sort of for resources and answers. Next question. At what size should an abdominal pseudoaneurysm be repaired? My surgeons recommended a stent. Is that the best method?
I think this sort of follows my general theme that I'm a little hesitant to recommend stents for repair of aneurysms. However, pseudoaneurysms are a little bit of a unique thing in terms of their morphology. So if there's a possibility to place a stent where it would not significantly alter a future open surgery if that stent failed, then I think that would be okay. If the stent is going to increase the risk of a open operation to potentially salvage the stent by virtue of how the stent is placed or proximity to critical blood vessels off of the aorta, then probably it would not be the way I would go.
And Angela, we skipped one question above that.
Yeah, I was trying to, well, first of all, do you have any other thoughts on this one?
No, I agree with what Dr.
Okay.
Black said.
Do you want to go back to this?
Yeah, so
if you want to go back to this.
comment. Did we answer that one? I don't think we did.
No, I was going to save a couple of the more specific ones for the very end if we needed to, but you go, by all means, feel free to respond to that if you'd like.
That was just going to be a quick answer to say that, you know, the
Okay.
genetic report itself will tell you if this is a pathogenic variant or not. So if it is a pathogenic variant, then, and it should say in the interpretation of the report also the clinical diagnosis that goes with that. So if it's a pathogenic variant in TGF-beta receptor 1, then we're looking at Loeys-Dietz type 1. However, if it's a variant of unknown significance, or if it's rated as something else, because the genetic report, the genetic testing report will say that, then that's a different conversation to have with the geneticists themselves and the genetic counselors.
Thank you for that. That was the question in response to Bonnie, who had asked about having a variation and wanting to know a specific variation and wanting to know about her twin sister and son and daughter. Okay, moving down then, we will do, are downstream aneurysms common in ascending aortic replacement surgery? And if so, what is the average timeline for those happening?
So this would, again, depend probably on, you know, the patient's personal family history, you know, the risk factors that lended themselves to an ascending aortic aneurysm. But generally speaking, ascending aortic replacement is a very, very safe operation. It doesn't necessarily destine someone to require surgery down the road. I would harken back to the slides I presented where there was a long gap between an elective ascending repair and then a future aortic dissection. So it could be, you know, decades before another operation could come into play.
Okay. Dr. Shalhub, do you want to weigh in, or are you good with that one?
No, nothing to add. I agree with that.
Okay. Here's another one. Again, we're getting a little bit more specific with some of these as we get toward the end here, but we are close on time, so we'll have a few, we probably have time for these. So my son at age 12, who's now 14, had his aortic arch replaced with a stent graft. After learning about dissections with these grafts, do you recommend surveillance more than twice annually?
It's hard to answer specifically, again, going back to like in general, I think twice annually is reasonable, but it really depends on the type of the graft and where the graft is seated and how it's seated. Like, is it already sewn in to an arch replacement, for example, which would give it a very stable platform versus if it's only in the descending aorta? Because normally at the moment, we're not performing arch stent grafts that cover the origin of the arteries that are feeding the brain. So those are the innominate, the carotid artery, and the subclavian artery. So there must be more to this question. You know, there must be more detail to this question. So it just depends on the patient themselves.
Also understand that many of the aortic arch stent grafts are currently not available in the U.S. If there are aortic arch replacements in the U.S., they're mostly done on an investigational basis, and there's probably only, I believe, 5 or 6 people who have access to such aortic arch stent grafts. In Europe, they're actually quite common, and that just is the nature of the beast with the FDA versus the European approval process. So again, I would agree, Sherene comments that it really is a very specific question and speaks very closely to the nature of the technology.
Good point. I know we've had many discussions within our team about those different approaches in different parts of the world. Okay, why no ARB monotherapy for LDS patients?
Yeah, if you noticed when I gave my talk, I blew through that really quickly because I realized that that was a cut and paste off of a slide for Marfan syndrome patients, of which a study suggested that beta blockade was protective for type B dissection. So for Loeys-Dietz syndrome patients, the ARB monotherapy is certainly reasonable. It's again, under the guidance of your genetics team, and aortic surveillance can be done very safely.
next question then, unless Dr. Shalhub has anything she'd like to add to that.
No, but we can take the next question about the malperfusion. So this is normally when we talk about malperfusion, we're talking about something that happens when somebody has a dissection. And so usually it's in the quote unquote the acute phase at the time of presentation or shortly thereafter when the dissection happens. So when we see, for example, malperfusion to the spine, we're talking about paralysis or numbness or tingling in the legs, basically that the spinal cord is not getting enough blood flow. And then when we see malperfusion to the kidneys, we're talking about that the kidney function would be impaired, where the kidneys are not working well. And usually it's in the setting of an acute dissection in the acute or subacute phase. You can see perfusion issues during surgery, which is, and I'll go back to Dr. Black's slides where he showed the open operation, where we're trying to maintain blood flow to the spine during when we do the thoracoabdominal aneurysm repairs or even the descending thoracic aortic repair. We're trying to maintain blood flow to the spine because the arteries that feed the spinal cord come off the aorta at those levels. And so we have, what we call adjunctive maneuvers to improve the flow to the spinal cord during those operations. So two different scenarios in which you can see perfusion problems.
Okay, next question is, can you expand more on the complication with the VATS pleurodesis, especially if done on the right side, surgery and vascular surgery? What would an aortic root repair look like in this case?
A VATS repair, or a VATS pleurodesis, I should say, on the right side really should not affect a ascending aortic repair or a root repair, or for that matter, a repair of the descending thoracic aorta. So right side is really not an issue for most of the surgery one would have to consider for Loeys-Dietz syndrome.
Okay. Next question is about beta blockers, a specific, sort of jumped there on us. Specific beta blocker that is recommended. Is it for blood pressure control? What if blood pressure is low but resting heart rate is high? Is high heart rate an independent risk factor for aneurysm or dissection?
So I would say I don't choose a specific beta blocker. I work with our cardiologists pretty closely, but my understanding is that they prefer what we call a third generation beta blocker in that for people with aortic dissections or as a prophylactic. We do know there was a large study in Marfan syndrome, which was the carvedilol trial, where they did carvedilol versus losartan in children with Marfan syndrome. So our cardiologists tend to use carvedilol, but again, that can also vary depending on the side effect profile that you have. The blood pressure, I mean, the goal is to maintain a blood pressure to be low, and my preference is in the 100s to 120s, as as high as I'd like to see somebody, as high as 120, but not much higher than that. We tend to be very restrictive in terms of that. But I'm not aware of data specifically saying that elevated heart rate is a risk for dissection. It's usually the spikes in blood pressure that are usually thought of as being an issue for risk of dissection. Jim, do you have any additional insight into that? What do you do at your clinic?
Yeah, same thing. Yeah, I think if someone is wanting to be particularly aggressive about exercise, I'll introduce the notion of beta blockers, maybe for extra protection, again, for the same reason, to avoid those spikes.
Okay, last question in here, and then we'll be wrapping up for the evening. At what size should surgery be considered for ascending aorta?
Presumably for a teenager or near adult or an adult, the diameter for the ascending aorta could be 4.5 centimeters to 5 centimeters, sort of depending upon body size, body mass index, body surface area. There are some adjustments that can be made to fine tune the exact number, but the range could be as low as 4.5 and generally above 5. Most people are recommending surgical replacement.
And certainly if it's a woman and she's considering pregnancy, we also have a discussion early on that may lean down towards even a smaller size, but it also depends on the kind of variant that we're looking at, whether it's a TGF-beta receptor 1 versus a SMAD3. That also matters in that discussion that we have with the women who are wanting to be pregnant.
That's a great, great point to finish that up on there. Thank you to both of our presenters for this evening. We are so grateful for your time and your expertise in helping us offer such a tremendous whole E3 summit. If you have additional questions that either we were not able to get to tonight or during this presentation, or others that occur to you later on, you are encouraged, please submit them to marfan.org/E3ask. We are always available to take questions. Please bear in mind that they may take a little bit of extra time to get a response back to you during this time, but we will do our very best to get all of those questions answered. Also, before you exit, wherever you're viewing this session from, there should be a rate this button to click at the bottom or underneath your viewing screen. We would really love for your feedback on this session and every session you attend during E3. Don't forget to visit the exhibitors in our virtual exhibited hall, and if you haven't yet explored the community threads and discussion topics within the HUVA app or on the website, please do. There's so much activity going on that I can hardly even keep up. It's so neat to see so many people connecting with each other on just such a range of topics and connections in ways that we would never get to connect. And if you are on social media and want to share anything about your experience or encourage others to attend, of course, we would always be excited for you to refer this to others who get this information. But please be sure to use the E3 Summit 20 hashtag. So thank you again to everyone. And would like to watch this presentation again, it has been recorded. We will be posting that recording under this same link where you attended tonight for viewing all throughout the summit and at least a little while into the future. Thank you both, Dr. Black and Dr. Shalhub, and thanks to all of our attendees.
Thank you very much, everyone. Have a good night.
Thank you. Have a good night. Bye-bye.